Hey folks, this is Eric with FlightBridgeED. Welcome back. I'd like to take a little bit of time and do a two-part podcast series on 12-lead interpretation. I'm not going to go into depth on, from start to finish on initial management and things like that. I do want to talk about the high acuity patients and really emphasize some certain points with that. When I teach 12-lead stuff, I really like to associate everything with the anatomy of the heart, the anatomy of the coronary arteries in specific. I also want to talk about, the left bundle branch blocks, the mimickers that really get us hung up, and that's going to be more podcast number 2, where we're going to look at left bundle branch blocks, and we're going to talk about Scarbosa criteria and how we can identify acute coronary syndromes in conjunction with left bundle branch blocks or right bundle branch blocks. Initially when I learned to do 12 leads and teach 12 leads back in the late 90s, early 2000 area, we had an exclusion criteria for left bundle branch blocks. If we didn't or couldn't identify if this was a new or old finding, then our patients basically were left to be taken to the ER, and we weren't allowed to take them straight into the cath lab. 60% of left bundle branch blocks in conjunction with acute coronary syndrome are associated with pump failure. And the mortality and morbidity rate is 40 to 60%. So it's really, really important if a left bundle branch block is in association with acute coronary syndrome that we get these patients reperfused. So let's start talking about our high acuity patients, and we're going to briefly go through and talk about the anatomy, coronary anatomy. I think, again, that's very, very important to understand our treatment approach, maybe potential problems that you're going to see down the road, and really understand where that occlusion is based on your interpretation of your 12 lead. So we're going to kind of jump in. We'll hit the coronary arteries in specific order. We'll start with the right side and then go to the left side. So remember, our right side of our heart is responsible for preload, right? Everything comes into that right side, comes into the right atrium and goes into the right ventricle, and it's deoxygenated. It goes and it gets oxygenated through the pulmonary artery into the lungs, and it comes out into the left side. And so, preload is obviously very important for afterload, right? And afterload is important because that's what gets ejected out into our tissues, our brain, our kidneys, and things like that. With the right side of the heart, we have a main coronary artery that supplies that. It supplies the SA node, the AV node, the right atrium, the right ventricle, the inferior wall, and the posterior wall is the right coronary artery. And you're going to see the occlusion here is going to affect the inferior wall when we see this on a 12 lead, and the posterior wall. Most often, though, a posterior involvement is always going to be associated with an inferior infarct, and we really don't take the time to do a posterior 12 lead. There's ways to identify a posterior MI in conjunction with an inferior wall MI. The other big aspect of a right-sided MI like this is a right ventricular infarction, and we know that if we blow out that preload, or we cause that right ventricle to pump or work insufficiently, we're going to have major preload problems, and that's going to relate or cause poor afterload problems. So it's really important in these MIs, when we have an inferior wall MI, to identify if we have a right ventricular infarction. And the incidence is actually pretty high. It's close to 50%. And we can do what's called a right-sided 12 lead, where you do V4R. You put a lead over on the fourth intercostal space, midclavicular, and you push print again, and you look at V4 on your precordial side of your 12 lead, and you see if you have ST elevation, and that's 98% accurate. You don't need to do multiple leads on that right side. You just do that one. So that's very important, because we want to limit our nitrates, we want to limit our morphines, anything that's going to cause a profound vasodilatory effect. We want to really load them up with fluids and optimize that preload that way. With our left side of our heart, obviously we have the left ventricle. It's responsible for, propelling that oxygenated blood back out through the aortic valve and into our brain and our tissues and our kidneys and things like that. But remember, with our left ventricle, that can work in very poorly based on the number one thing is hypertension. Hypertension causes many problems throughout the body, but the big thing is it causes excessive stretch. The left ventricle has to work harder. It's called the Frank Starling effect, and so it's got this excessive stretch. It's having to pump harder. It doesn't work as efficiently, And with any muscle that works harder, it grows and it starts impeding that chamber inside, so that muscle gets big, and that's where you have that left ventricular hypertrophy. So that decreases afterload, decreases oxygen-rich blood going to our body, and that's where we can start getting fatigued, and later on progresses to congestive heart failure. The main coronary artery that branches off there or supplies that whole left side supplies obviously the left atrium, the left ventricle, the bundle branches, the Purkinje fibers, all those things is the left main. And the left main branches down into the left anterior descending artery, and then it branches also off to the lateral wall via the left circumflex. And we'll talk about the left circumflex, and there's a few incidences where people are what's called left anterior descending dominant or left main dominant. And what that means is that left circumflex branch, it's an abnormal thing where anatomy-wise, where it goes back and it continues around it actually feeds that inferior and posterior wall. So where you would normally only have a right coronary artery occlusion for an inferior wall MI, this is where you would see an inferior lateral infarction. So you'd have ST elevation in, let's say, 2-3 AVF, or remember you have to have two contiguous leads, so you just have to have two of them, 2 or 3, and you would also have infarction or ST elevation in your lateral leads. And remember, our lateral leads are 1 AVL for our really high lateral wall, and then V5 and V6 for our lower lateral wall. So if you had two contiguous leads in our inferior wall and two contiguous leads of elevation in our lateral wall, that's called a left or a inferior lateral infarct, and we know that is caused from an occlusion in the left circumflex branch. So those are just some quick ways to identify kind of where your infarction is, and it's very important. We talked about our right side and how important it is to identify if we have a right ventricular infarction. Same thing with our left main. If you have infarction that is causing ST elevation in our septal, our anterior, and our lateral leads, based on that occlusion is in a really high spot. It's above that circumflex branch, and it's occluding the whole side. So that's what's called a widowmaker. You're going to have these massive, huge tombstone T waves in V1 through 6. Remember, we have the IC all leads mnemonic, whereas the I is inferior, and that's 2-3 AVF. And then you branch over to the precordial leads. When I say precordial leads, I mean V1 through 6. So V1 and V2 are septal, V3 and V4 are anterior, and V5 and V6 are the lower lateral wall. And then you have 1 in AVL. They're going to be your high lateral wall. So I think it's really important to know where your occlusion is, or try to identify that. Obviously, if you have a really high occlusion, you have everything involved from septal to lateral, and you have elevation globally like that. You could potentially have massive pulmonary edema. You can have bradycardia, hypotension, severe cardiogenic shock with those types of patients, because our left ventricle is just not working efficiently at all. So that's really important to understand, and it can give you a good idea of the approach and how aggressive you might want to be with everything from airway to medications and pacing and things like that. So again, I'm not going to be able to show you different 12 leads and things like that. I will post some 12 leads on the forum, and we can break those down. I'll probably put some tougher ones on there. But remember, when we start talking about our ST elevation, we're trying to identify two contiguous leads. Most protocols are saying 1 millimeter of elevation, so we're going from the J point, which is basically from the start of that S segment. So we have the Q, the R, and the S is the very bottom notch, and it's the beginning of the ST segment. So from that point, that J point, down to the isometric line, we're measuring to see if we have at least 1 millimeter of elevation. And we have to have two contiguous leads. So when I mean two contiguous leads, you have to have, in the inferior wall, you would have to have 2 out of the 3 of 2, 3, or AVF. And then for the other ones on the precordial side, it's always grouped in 2s. So you have, V1 and V2 would be septal, V3, V4, V anterior. One thing to remember, and you may see this quite a bit, is if you have a doctor may group V1 and V4 together. He or she may say, well, this is an anterior MI, which is totally fine. If you look at a picture, the septal wall lies right in the center of that anterior wall, and really it's the same thing. It's all grouped together. It's not going to change anything. So very important to remember that it may be termed a different way. So at this point, we're going to go in and we're going to identify our MI, and everything is good. If we can identify 2 contiguous leads, we can identify 1 to 2 millimeters of elevation based on your protocol. Everything is good, and we need to remember we need to activate a cath lab or do a STEMI alert as quickly as possible. Try to incorporate your 12 lead interpretation as early on as possible in your patient care. If you're on an ambulance and you go into the house and you identify this is a candidate for a 12 lead, do it quickly. Do it within the first 2 or 3 minutes, and then make a decision based on your location, your demographics, etc. Know where your cath labs are. Know the distance. If you need air medical, then activate air medical. If you're going to the call and it sounds like a legitimate cardiac event, put an air medical helicopter on standby. You can always cancel them. I've worked for many air medical services. All of them were the same. They don't mind to be canceled. Put them on standby. Have them at high alert, and they don't mind being stood down. If you are 15, 20, 25 minutes from a cath lab, then it's more than appropriate to go by ground and get them to the appropriate facility. But just know your demographics, know where you're at in location. Obviously, there are other aspects of 12-lead interpretation that could kind of fumble you up, and we're going to talk kind of more in depth in podcast number 2 regarding that, but we'll just hit that really quick, and then I'll recap that, and we'll start from scratch in podcast 2. We have bundle branch blocks. Remember, bundle branch blocks are something that can mimic ST elevation MIs. It can cause depression. It can cause massive T-wave, hyperacute T waves. It can cause real wide QRS complexes, etc. So it can make everything all over the 12 lead look very poor, make it look like there's global ST elevation all over the place. Remember, though, there's only one other incidence, and that would be like a pericarditis, where you're going to maybe see that, and it's very unlikely that somebody's going to have an MI in multiple coronary arteries that's going to cause a global ST elevation like that. So those types of patients are going to die. You're not going to ever see that. So if you see that, that's a bad thing. So we want to identify mimickers, and so other mimickers would be pace rhythms. Remember, pace rhythms nowadays, the pacer spikes are very small, they're hard to see, and it can make the QRS look very wide and terrible. Benign early repolarization is a manifestation that's a physiologic thing that some people just inherit. It's predominantly in 20 to 40-year-old black males, and I've only seen it one time, and it basically causes this mild little ST elevation. It looks like a fish hook, and it can kind of trick you. And then obviously you have pericarditis, where you're going to have to look at their presentation. Have they had a viral illness? Have they had some type of illness? Do they have chest pain that is relieved when they lean forward? Things like that. So remember, everything we do is based on a good assessment, and doing pertinent negatives and talking about the quality and the presentation of the 12 lead and how sharp it is and does it radiate and things like that. And that's going to clue you in based on your 12 lead. You use all of these tools to make a decision, to form a diagnosis, to look at your treatment path. So that's always really important. So remember to study 12 leads, look at it systematically. I'm going to jump into that in podcast number 2 on how I look at a 12 lead, and it kind of keeps you out of trouble. We're going to go into the left bundle branch blocks in specific order, and then we're going to go into the right side and go into the other mimickers, maybe real slightly, or I'm not going to go into depth on those, but we're going to really focus on the Scarbosa criteria and trying to look at these left bundle branch blocks and identify if this is an association with acute coronary syndrome, or if this is just a normal physiologic thing that some people have. I want to thank you for joining me. The website is up and running. I'm getting a lot of good feedback on it. I'd love your comments, good or bad. Look at the podcasts. Leave your comments so we can improve this. This site is truly for everybody. We have the forums pages up, and what I plan on doing with that is any podcast I do, if it's a strong enough podcast, I'll put patient scenarios, I'll put literature, I'll put pictures and things like that on there. We'll put real tough patient presentations, and we'll have different moderators from around the country that are maybe experts in their field, and they'll moderate your patient care and how you plan on approaching that patient. I think it's going to be a good thing. It's going to foster some learning from the moderators, myself, and hopefully you. And we really encourage your involvement in that. So we do have a Twitter account now. You can follow us on Twitter at FlightBridgeED, and we'll be posting things, new things that are coming up, podcasts, things like that. So I want to thank you for joining us, and I'll talk to you soon.